Lecture series, and this is the orbit part 4, and in this part we are going to discuss about the non-infective inflammatory disease, and it is very common. So in this part we will discuss about the idiopathic orbital inflammatory disease. We will discuss orbital myositis, acute dextroadeninitis, and Tolosa Hunt syndrome, granulomatous with polyangiitis. So, first, I would like to tell that basically it is a non-infective etiology, means no infection is the cause of this inflammation, and there will be the inflammation. Idiopathic orbital inflammatory disease is also known as a pseudo orbital pseudotumor, IOIT, and basically it involves the all the muscles of the orbit, whereas orbital myositis is also the inflammation, but it involves usually a single muscle belly. So idiopathic orbital inflammatory disease, IOID, also called non-specific orbital inflammation or orbital pseudotumor, is an uncommon disorder characterized by the non-neoplastic, non-infective, space-occupying orbital infiltration with inflammatory feature. So there will be the inflammation at the orbit. The process may preferentially involve any or all of the orbital soft tissue. Histopathological analysis reveals pleomorphic inflammatory cellular infiltration followed by the reactive fibrosis. So there can be the active inflammation. After that, when the active inflammation settle down, it can lead to fibrosis as well. Unilateral disease is typically in adults, although in children bilateral involvement may occur. Intracranial extension is rare. Simultaneous orbital and sinus involvement is also rare and may be a distinct entity. So how will you diagnose and a cases of an orbital lesion? So with any case of the orbital lesion, there can be a condition called proptosis with it. So typically symptoms include consist of the acute and subacute ocular and periauricular redness, swelling and pain. Systemic symptoms are common in children. So signs can be that there can be pyrexia in up to 50% of the children, but it's rare in adults. There can be a congestive proptosis. So there can be proptosis which is with the redness of the eye. Mild to severe ophthalmoplegia can occur. Feature of optic nerve dysfunction, particularly if inflammation involves the posterior orbit, there may be optic disc swelling. Choroidal folds, if present, may be associated with reduced vision, but optic neuropathy must always be suspected. So, with any kind of the orbital inflammation, you can see the optic nerve dysfunction as well. So, how the course of the disease? There are three courses of the disease. So, the natural history of the inflammatory process is very variable. Spontaneous remission after a few weeks without sequelae. So, one thing is that that inflammation will just settle on its own after a few weeks without any other sequel. Second is that there can be the intermittent episodes of activity, usually with eventual remission. So, a patient may present to you with getting a episode, then have a few weeks of inactivity, and then after a episode of activity, and then there will be the eventual remission. Severe prolonged inflammation eventually leading to the progressive fibrosis of the orbital tissue, resulting in a frozen orbit characterized by the ophthalmoplegia, which may be associated with ptosis and visual impairment caused by the optic nerve involvement. So there can be the fibrosis of the orbital content, which leads to ophthalmoplegia, also known as a frozen orbit. So CT scan is a very important in the case of orbital disease. It helps us to distinguish different kind of lesion. So what will the CT scan show us? The CT scan will show ill-defined orbital opacification and loss of definition of contents. So you can see this A is showing a left idiopathic orbital inflammatory disease. B is showing the CTL axial we are showing ill-defined orbital opacification. So there will be the orbital opacification, but there is no defined orbital opacification. Biopsy is generally required in persistent cases to confirm the diagnosis and particularly to rule out neoplasia, systemic inflammatory condition. A wide range of other investigation may be considered to aid in the exclusion of alternative diagnosis, particularly infection, lymphoma, and non-neoplastic infiltrative disorders such as sarcoidosis and vaginal granulomatous. So, if you give the patient after ruling out any kinds of infection, you give the patient a steroid. If the steroid is not helpful, and you have performed CT and there is an ill-defined mass, then you can go for the biopsy to confirm any to rule out any neoplastic lesion. So treatment can be with the observation for relatively mild disease in anticipation of the spontaneous remission. NSAID alone, for example ibuprofen, are often effective and may be tried in mild disease prior to steroid therapy. Co-prescription of a proton pump inhibitor should be considered. So you know that a steroid and NSAIDs are cause the stomach gastric problems. So you must give proton pumps inhibitor for the gastric protection along with the steroids as well. Systemic steroids should be administered only after the diagnosis has been confirmed, as they mask other pathologies such as infection and vaginal granulomatosis. Oral prednisolone is initially given at a dose of 1 to 1.5 mg per kg per day, subsequently being tapered and discontinued after a number of weeks depending on a clinical response. Further treatment may be needed in the event of recurrence. Orbital depot steroid injection may be useful in some cases. So you can also give the local steroid injection. Radiotherapy may be considered if there has been no improvement after 2 weeks of adequate steroid therapy. Even low dose treatment, for example 10 GY3, may produce remission, though much higher total dose may be necessary. Other options, usually as supplementary treatment or in resistant cases, include cytotoxic drug, for example methotrexate, azathioprine, calcineurin inhibitor, cyclosporine, tacrolimus, and biological blocker. Surgical resection of an inflammatory focus may be contemplated in highly resistant cases. So basically you know that it is an immunological disease, so you have to give immunosuppressants to treat the disease. You can get first mainstay of treatment is systemic steroid, but if the systemic steroid is not working even after the 2 weeks, then you give the radiotherapy and it can cause remission. And other options are that you can use other immunomodulators such as methotrexate, cyclosporine, and biological blockers. And surgical resection is sometimes of an inflammatory focus is sometimes necessary in a highly resistant cases. So next here is an orbital myositis. Orbital myositis is an idiopathic non-specific inflammation of one or more extraocular muscle and is considered a subtype of IOID. So it is a subtype of IOID in which one or more extraocular muscle are involved. Histopathology show a chronic inflammatory cellular infiltrate associated with muscle fiber. Diagnosis, there can be acute pain exacerbated by eye movement and diplopia. Onset is usually in the early adulthood. Signs are generally less obvious than IOID. There can be lid edema, ptosis, chemosis, pain, diplopia associated with eye movement, vascular injection over the involved muscle. Very pathognomic that there will be the congestion over the involved muscle. So you can see this figure. It is showing orbital myositis. A is histopathology showing a chronic inflammatory cellular infiltrate in relation to muscle fiber. B is showing the vascular injection over the insertion of the right medial rectus. C is showing the coronal CT showing enlargement of the right medial rectus. In chronic cases, fibrosis of the affected muscle may occur with permanent restrictive myopathy. So there can be coarse, acute, non-recurrent involvement that resolves spontaneously within 6 weeks. So one is that it can resolve spontaneously. Second is the chronic disease characterized by either a single episode persisting for longer than 2 months, often for years, or recurrent attacks. Investigations consist primarily of MRI or CT, which show enlargement of the affected muscle with or without involvement of the tendon of insertion. This is in contrast to the TED related muscle enlargement, in which the tendon is always spared. Additional investigation may be required in some cases. So, why it is different? How do we different orbital myositis from a TED? Because in a case of a TED, there will be the tendon sparing lesion, but in case of myositis, the tendon will also be involved. So this is the basically difference between the TED and the myositis. Treatment is aimed at relieving discomfort and dysfunction, shortening the course and preventing recurrences. NSAID may be adequate in mild disease, but systemic steroids are generally required and usually produce dramatic improvement. Although recurrence is seen in 50% of radiotherapy, is also effective, particularly in limiting recurrences. So, mainstay of treatment of any kind of immunological disease is the steroid therapy. Next is an acute dacryoadenitis. So, it is basically the inflammation of the lacrimal gland, and it can be due to some idiopathic, or it can be viral, or it can be secondary to a Sjogren's syndrome. So, acute dacryoadenitis may be idiopathic or due to viral, for example, mumps, Epstein-Barr, and cytomegalovirus, or rarely bacterial infection. The lacrimal gland is often involved in IOID. Chronic conditions such as sarcoidosis, Sjogren's syndrome, thyroid disease, and some chronic infection usually give a less acute onset, and involvement can be bilateral. So, there are certain systemic conditions such as sarcoidosis, Sjogren's syndrome, and thyroid disease. So, we are going to discuss these are basically all immunological diseases. In case of thyroid, which affects the thyroid gland, Sjogren's syndrome, it affects the lacrimal and salivary gland producing are affected, and in sarcoidosis most of the organs are getting infected, especially lungs. Presentation in acute diseases with the rapid onset of discomfort in the region of the gland. So where is the gland located? You know that this is an eyelid, and basically it is present in the supralateral part of the orbit, and if it is inflamed, it can cause the eyelid swelling, and it can also cause the dystopia as well, which is usually infranasal, because the if the gland is present in supratemporal part, so it will cause the proptosis in the infranasal part. So lacrimal secretion are may be reduced or increased, and discharge may be reported. Swelling of the lateral aspect of the eyelid over the palpebral lobe leads to a characteristic S-shaped ptosis. So you know that a lacrimal gland has two parts. One is a palpebral lobe and another is an orbital lobe. So when the palpebral lobe is involved, it gives rise to the S-shaped ptosis. An enlargement of the orbital lobe may give rise slightly downward and inward dystopia, and occasionally proptosis and other signs of the orbital disease. So I told you earlier that any lacrimal gland is present in the supratemporal area. So if the orbital lobe is involved, it will cause the dystopia in the infranasal position. There is a tenderness over the lacrimal gland, and an injection of the conjunctiva overlying the palpebral lobe may be seen on upper lid eversion. Chemosis may be present. There may be local, for example, pre-auricular lymph node enlargement. CT scan show enlargement of the gland and involvement of the adjacent tissue without a bony erosion. So if the bony erosion, you can suspect the if there is a bony deformity with the lacrimal gland inflammation, you can suspect tumor, but in the case of adenitis, there will be no bony erosion. The later suggests the tumor. Biopsy is sometimes indicated, particularly to exclude a tumor. Treatment varies according to the cause, but in many cases is not required. So this is the left dacryoadenitis. So you can see the swelling on the lateral side of the aspect of the lid, giving an S-shaped ptosis. B showing the injection of the palpebral lobe of the lacrimal gland and the adjacent conjunctiva. C is showing the axial CT showing enlargement of the gland and opacification of the adjacent tissue. So another very important is the Tolosa Hunt syndrome. Basically, it is an orbital apex inflammation. So whenever the orbital apex is being inflamed, there will can be the condition called ophthalmoplegia, because all the nerves are passing through the optic as through the apex. So there will be the ophthalmoplegia, and there can be the proptosis as well. Tolosa-Hunt syndrome is a rare idiopathic condition caused by a non-specific granulomatous inflammation of the cavernous sinus, superior orbital fission, and or orbital apex. If it is a diagnosis of exclusion, so very important, when you rule out every other diagnosis of ophthalmoplegia or inflammation, you can say it is a Tolosa-Hunt syndrome after ruling out every other condition, and should be investigated fully. Presentation is the ipsilateral, periorbital, or hemicranial pain and diplopia due to oculomotor paresis with pupillary and eyelid involvement in many cases. Proptosis, if present, is usually mild. Sensory loss occur along the distribution of the first and the second division of the trigeminal nerve is common. The patient may be pyrexial. Diagnosis is with the imaging together with other investigation to rule out identifiable cause, including neoplasia. Treatment is with systemic steroids and other immunosuppressants as necessary. The clinical course is characterized by the remission and recurrences. So basically, the patient will, because all the nerves are passing through the orbital apex and cavernous sinus. So when it is inflamed, it will cause the distortion of all the blood supply, for example nerve supply, like you will have the oculomotor paresis, there will be the pupillary involvement, there can be the eyelid involvement, and the first and the second division of the trigeminal nerve can also be affected. So you can give the treatment with the systemic steroid to treat this condition. Another very important disease is granulomatous with polyangiitis, which is also known as a vaginal granulomatosis. Why it is important? Because it is usually related to a sinusitis. The patient usually present to you with the sinusitis, with the history of sinusitis, and then with the orbital inflammation. So in such cases, you can also always suspect the granulomatous with polyangiitis. And one of the very diagnostic tests for it is the C-ANCA. So granulomatous with polyangiitis, previously called vaginal granulomatosis, is an idiopathic multi-system granulomatous disorder that involves the orbit, often bilaterally, usually by the contagious spread from the paranasal sinuses or the nasopharynx. Primary orbital involvement is less common. This condition should be considered in any patient with bilateral orbital inflammation, particularly if associated with sinus pathology. Antineutrophilic cytoplasmic antibody C-ANCA variant is usually a useful serological test. So we have discussed all these things. Other ocular features include scleritis, peripheral ulcerative keratitis, intraocular inflammation, and retinal vascular occlusion. So vasculitis can also happen in a case of the polyangiitis. Treatment is with the cyclophosphamide and steroid, which are usually effective. So very important, you have to treat it with the immunosuppressant because it is also a inflammatory disorder. With the cyclophosphamide and steroid, which are usually effective. In resistant cases, cyclosporin, azathioprine, anti-thymocyte globulin, or plasmapheresis may be useful. Surgical decompression may be required for severe orbital involvement. So these are all for the non-infective inflammatory disorder. So see you in the next lecture.